Okay, this is another hodgepodge of topics. We'll start by talking about the Propaq and then some other special circumstances. So the Propaq is the device we have that's the automatic monitor. It's a supplement to your assessment. It doesn't replace your exam or any of the skills that you have. All patrollers can do the non-invasive blood pressure with it, pulse oximetry, and the heart rate by pulse ox. For the physicians, we've got 3-lead EKG and end-tidal CO2, and that stuff's kept in the physician box. So we're going to practice this as a skill. I want you to get manual vital signs, but if you're monitoring someone over time, you can use the Propaq as well to monitor them over time. If we ever have to deal with a sexual assault patient, treat the injuries as much as possible, preserve evidence, and contact law enforcement. If we have a patient who has a do not resuscitate order, or we're considering whether or not to resuscitate someone, there's a couple things that need to go through our mind. So if you've got obvious signs of death, they are stiff, they've got a purple line on their body, dependent lividity, they're decapitated, they're decomposed, they're incinerated, or they're missing half their body, any other lethal injuries, you don't have to, don't start resuscitation on those people. In any trauma arrest, you could consider not starting resuscitation. And if it's somewhere where it's not going to adversely affect the public in our operations, I would say if you have a trauma arrest, don't work it. It's now a death and a crime scene. DNR forms, orders from patients do not resuscitate. An EMS do not resuscitate order, a non-EMS do not resuscitate order, including what are called PULSed, for provider or physician orders for life-sustaining treatment, or MOLST, medical orders for life-sustaining treatment, are acceptable if they say do not resuscitate. And then main EMS has its Comfort Care DNR program. Treat those patients the way that you would any other patient right up until the time they go into cardiac arrest. If they go into cardiac arrest, then you don't do anything. But up until the point they go into cardiac arrest, a DNR means just don't resuscitate. It says nothing else about their care. Now they may have, on the PULSed or MOLST, they may say provide comfort care only. And if they do, provide comfort care. But otherwise, treat them exactly the same as you would any other patient up to the point they go into cardiac arrest. When do we stop resuscitating a patient in cardiac arrest? Well, if we get him back, we stop. That's a wonderful thing. If equally or higher trained personnel arrive on scene, that's a wonderful thing. If you become physically exhausted, you stop. If the patient's personal physician or online medical control tells you to stop, you stop. And what's likely to happen, because of the fact that we're going to be doing in-place resuscitation for at least 10 minutes and preferably 20 minutes, is by the time EMS arrives, they're going to initiate their in-place resuscitation for 20 minutes, and then we'll collectively stop. There's a whole protocol on death situation guidelines for you. Review it on your own. Hopefully we'll never have to deal with that. General responsibilities for deceased patients in mass casualty incidents. Review that on your own. And that's it for that hodgepodge. So go ahead and complete the knowledge assessment on those.